And so, Jason, if you see pyrexia in a dab-trem-treated adjuvant patients, how do you try to minimize it or avoid it or manage it? What do you do?
Well, my experience, especially in adjuvant patients, is that it's quite prevalent. And so there's the on-label number that you see, but in my practice, it's very common. But I tell them patients outright from the very beginning, from the first conversations, that if we go this route, be aware it's okay if you take a break. If you get any symptoms that you think are consistent with a fever, whether it be fatigue, sweats, and so on and so forth, then stop and give us a call and let us know, but just let it wash out. Because I feel like what the patients really need is that information to empower them. They don't want to stop. But if you tell them it's okay, then we keep going. So I usually, and a lot of our patients do get the fever, and we'll give it a shot, take a break, come back to it, maybe to give it a try again. But we don't, in the adjuvant setting for sure, we're not going to belabor it over time. So there are a rare group of patients who really just don't seem to be able to get out of the first month without just having continuous fevers. I think those patients self-select for not great adjuvant therapy candidates, at least with targeted therapy. But generally speaking, I feel like empowering the patients, letting them know it's okay to take a break, allows them to kind of manage it themselves to get through.
So de facto, you're going to essentially do intermittent dosing?
Yeah.
Do others do that?
Well, I would say that the concept of intermittent dosing is a little different in that there are kind of proscribed breaks of weeks long, and then you restart at the high dose again. For the BRAF-MEK in this setting, the interruptions can be very short. So as long as a day or two sometimes is enough for patients to break their fevers and be able to be retreated. And so I wouldn't consider it interrupted dosing per se.
I would agree with that, but remember that some of the paradigms we have in managing fever in the metastatic setting do not hold in the adjuvant. And I would never put a patient on low-dose prednisone for fever. And the question for me becomes, if we're beginning early and we're seeing this toxicity, how will that affect switching to some other type of adjuvant therapy? Because there can be even more toxicities there.
You mean you're going to need to take a break from, if you go off dab-trem, you need to give them an interval off any therapy?
Absolutely, an interval.
And I guess also this also goes to show that all of these studies, the 3 studies that we're talking about, are used to 1 year of treatment. But in reality, we don't really know what the optimal duration of treatment is. So I think that again, but I guess from my perspective, also seeing these patients come back to me and they're on these treatments, I also said that it's not an all or nothing like you said, Jason. I think it really is that we have to sort of say this is to try to decrease the risk of this coming back, but they also have to live life. So it's also not an all or nothing.
And Robert, any concerns about the long-term use of Nivo? I mean, it's going to be used, or Pembro. Well, it's a year. I mean, that's a fairly long time. But are you seeing in patients that come back to you who've been on adjuvant therapy, when you check them, are you seeing long-term side effects that you didn't expect?
I think that some of the ones that we are seeing, the more serious ones, we have had patients who've had type 1 diabetes who've come back. And I think that, again, if you're 32 years old and now you have type 1 diabetes, and I think that occurs in about 3% of patients that will get on these studies. That is, to me, concerning, is that what is the long-term effect of that, especially if you have a patient that had an earlier stage disease, one of those stage 3B patients that was on that had a relatively lower risk of recurring than others. What's the long-term effect in terms of end organ toxicities and so on? I think, and those things we don't know yet. And to Michael's point, as you pointed out, and also as Hussein pointed out, that these are long-term toxicities that we don't know the effect of yet. Not even in the metastatic setting do we really truly know what the long-term effects are for some of these therapies.
And then what about, to close the loop on the adjuvant choices, any role left for high-dose IPI, which was approved in the U.S. at the end of 2015, so that's a little over 2 years ago, but probably has not been approved in the EU, Australia, Canada, probably never will be, but is there a role for that? Hussein?
So the first time I had to consider that after the approval of adjuvant nivolumab was actually a couple of weeks ago, where one of my patients on adjuvant nivo progressed with resectable disease. And so for those patients where, he's declared that he's a very high risk, and now even on PD-1, which we don't fully understand the biology of that, but it's clearly high risk enough that, from my perspective, he will require adjuvant treatment after resection. Obviously, again, this is a population that's never been studied, because all of the patients that were treated with adjuvant ipilimumab were basically patients that had never received immunotherapy or PD-1 in the past. But that's where I see a potential role when I feel that this patient has a high risk of recurrence after surgical resection of a recurrent disease. I actually considered, I'm going to have the patient come in next week to have that discussion, but I will offer adjuvant ipilimumab.
Remember also that this is a 10 milligram dose in someone that you're talking about that has a very high risk of metastatic disease who's clearly failed PD-1 therapy. And we know in the metastatic setting that that dose had better long-term 5-year survivals. I just can't turn my back to that in a setting where they're metastatic for all intents and purposes. Their risk is so high, and that once they are deemed clearly metastatic, you're going to give them a dose that's inferior at 3 milligrams.
Although that's what I will do. I mean, I acknowledge there is a modest augmentation in response rate and survival, 10 versus 3 in the metastatic mode, but it's a tough sales pitch to have a 33% rate of stopping from toxicity and a 41% rate of grade 3-4 side effects in a stage 3 patient. But, you know, I've had a handful of patients who've, like Hussein's patients, BRAF wild type, relapsed after adjuvant nivo, re-resected, and then put them on IPI.
Well, I'm sure Robert's going to make the same point I'm about to make here, but I think probably the recurrence matters a little bit in terms of what we're talking about here. So if you know, they had one node that was positive and it turns out they had a recurrence with one node, I think I would be pretty cautious about exposing that patient to potential long-term toxicity. Now, if they, you know, if it's a substantive recurrence somewhere that can be resected and then they're free of disease, then I think these arguments are much stronger.
Yeah, I think that from a surgical perspective also, this is really important to say, and as you pointed out also, Jason, I think that the site of recurrence is important. Is this a kind of a local recurrence within the incision, the wide excision itself, or is it in the lymph, or regional recurrence in the lymph node basin? I think those are very different compared to having lung and liver metastases recurrence. Additionally, the kinetics of that recurrence is also very important. Are the patient currently receiving treatment with in an adjuvant setting, and they are recurring and sort of breaking through that? From my perspective, those are really the same as kind of progressing for metastatic disease who are on treatment.